Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maximum Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has muted so you hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all to our guest speaker. Joining us today, we have Dr. Laura Yockey. Dr. Yockey is currently a rheumatology fellow at Mass General. She completed her residency training at Mass General and MD PhD training at Yale. She is interested in caring for patients with scleroderma and has a research interest in the topic as well. In recognition of Scleroderma Awareness Month, she joins us today to give a talk on the topic. Also joining us is Dr. Flavia Castellino. Dr. Castellino is the director of the Scleroderma program at Mass General, and she'll be participating today during the Q&A session. So please join me in welcoming them both.
Right. Great. Well, thank you everyone for being here today. And thank you so much for the introduction, Amy, and for organizing this talk. So today I'm going to talk about scleroderma and give a pretty broad overview of how it might present, how we diagnose it, and our approach to treating. So sort of some overview of how we treat the different symptoms involved. Again, as Amy said, I'm a rheumatology fellow in my second year, and I have a particular interest in caring for patients with scleroderma, but also this year I've been getting to spend a lot of my time doing research in scleroderma as well. And again, I have Dr. Castellino here with me too, who I've gotten a chance to learn a lot from this year, and is the director of our scleroderma program and will help us answer any questions too. And it's helped me prepare this presentation. So I don't have any disclosures. And so just as overview of what I'm going to talk about today. First, I'm going to talk about what is scleroderma, what symptoms patients might present with, how we go about working up scleroderma and how we come to a diagnosis. And then sort of the different organs that can be involved and how the disease can manifest in patients. And then finally, some overview of treatment options. So first, what is scleroderma? I know this is a disease that can be is a rare disease. It can be confusing for many people until you're managing patients or have experienced the disease yourself. Essentially, scleroderma means from the Greek origin, hardening of the skin. The term scleroderma includes both systemic sclerosis, which is a multi-organ autoimmune disease, and morphia, which is a more or localized scleroderma, which can manifest as skin hard thickening that is localized in a particular area. And then of systemic sclerosis, it can have two different sort of subtypes, which I'll talk about today a bit. It can be limited or diffuse. Today this talk is pretty much focusing on systemic sclerosis, and I think a lot of times scleroderma, the term scleroderma can be used sort of interchangeably as systemic sclerosis too. But again, I know this is something that some of my patients have found confusing too, but again, you can sort of, again, for this talk, I'm pretty much going to be using scleroderma and systemic sclerosis interchangeably. And so again, I will go through a lot of the different manifestations of scleroderma, but essentially how to think of it is it's a disease that can involve multiple organs. The lung and the skin are some of the most commonly involved organs. And there are a few processes that seem to underlie a lot of the manifestations that we see. So one is fibrosis, which is essentially scarring. And again, this can involve the skin, the lung, most commonly. And then another sort of characteristic of scleroderma is it can lead to abnormal blood vessels, or vasculopathy. And then finally, we think there is an autoimmune component that's driving both this fibrosis and abnormal blood vessels, and patients can have some inflammatory symptoms as well too. And just a few of the symptoms, for example, fibrosis, this can result in skin thickening, a lot of the time involving the hand. Autoimmunity and inflammation can result in like inflammation of the lungs, for example, and then this vasculopathy can often lead to severe Raynaud's or ulcers in the fingertips, and sometimes can affect the blood vessels in the lungs as well. And the scleroderma is it can affect everyone very differently. So not all patient is going to have all of these manifestations, and every patient can be very different in terms of how much each of these manifestations affects their lives too. So what causes scleroderma? Shorter answer is we don't have a perfect answer why. We're not quite sure. It is a rare disease, so I think some of the estimates I've seen that about 100,000 people in the US are affected with systemic sclerosis, and a number more with the localized scleroderma as well. We do have some sort of risk factors associated with scleroderma, so scleroderma is more likely to affect women. We know there are certain genes that put you at the risk of scleroderma, but there's not one causal gene. And sort of similarly, you may be at increased risk if you have a family member that has scleroderma, but it's not an inherited disorder. And a few other things that we knew that people of African descent are more likely to have severe disease. And then there are some studies that suggest certain exposures increase the risk of scleroderma, but it's not causal, and not everyone who has scleroderma necessarily has these exposures. So how might patients present, and what symptoms might patients have that prompt us to evaluate them for scleroderma? So one of the first manifestations for most patients is Raynaud's, which I'll talk about in a bit, which is sort of spasming of the blood vessels in the fingers. Another manifestation that's common in early part of scleroderma is thickening or puffiness of the skin. Again, usually this involves the hands first. And then if their patients have shortness of breath, are found to have particular diagnoses of lung inflammation or interstitial lung disease or pulmonary hypertension, those might be other presentations that prompt us to look, sort of evaluate more closely for scleroderma. Patients have a lot of other symptoms that they present with. They may abdominal symptom, heartburn, changes in bowel habits. They may have joint pain or stiffness, fatigue. These are all symptoms that sort of, when talking to patients about how their disease progressed, they'll highlight these, but these symptoms alone are common, and there are so many other things that cause it. So having heartburn wouldn't necessarily prompt us to work someone up for scleroderma typically. And a bit about Raynaud's, because I think this is an important thing to clarify with patients. And again, as for most patients, one of the first symptoms that may present. So Raynaud's is sort of cold triggered sensitivity and color changes in the fingers. So patients may be triggered if they're in the cold, or like holding a cold beverage, or going into the refrigerator section of the grocery store. And it follows a specific pattern where fingers will turn white, and then blue and red. And it may involve one finger or multiple fingers. The toes can be involved as well. And Raynaud's can be primary Raynaud's or not associated with any autoimmune disease, or it can be associated with a number of other autoimmune diseases, with scleroderma being one of them. So sort of some of the patients we see might have a new Raynaud's, and sort of we evaluate to try to see if there are other characteristics of scleroderma or other diseases that to explain why they have this. And then the skin involvement follows a particular pattern. So not all skin thickening would necessarily make us concerned for scleroderma. Usually patients can have limited disease. So where their face and then limbs sort of distal to the elbow and knees can be involved, or it can be a diffuse where it can involve sort of the upper limbs, the chest, the abdomen as well. And I'll talk a bit about why it's important to distinguish these two. And again, typically the pattern that we accept for scleroderma is that it often involves the hand first. And I think it's important to see that the hands are involved too. So for example, if someone has, it's very common for people have like venous stasis changes, they might have skin thickening around their legs, but that if the hands aren't involved, that wouldn't necessarily make us concerned for something like scleroderma and need to further. So again, not all skin thickening is scleroderma. And how do we work patients up for scleroderma? A lot of this, important part of this, we'll do a physical exam and history to ask for symptoms and exam findings that are typical of scleroderma. We'll do blood work, and then doing a heart and lung evaluation is an important part of evaluating patients with scleroderma. And again, this is often rheumatologists that may evaluate this, but other doctors may manage other symptoms too, like be part of the initial evaluation too. And our goal of our evaluation is to make a diagnosis to see if this patient meets the diagnosis of scleroderma. Some patients, they might have features that are concerning, but not quite have enough symptoms or exam findings to give a diagnosis, but we might worry they are at risk for developing scleroderma. And then another important part of this evaluation is to know what organs are involved and try to understand how currently and potentially in the future. And for some of the physical exam findings we look for, again, we'll do a full physical exam typically, but there are a number of sort of characteristics findings that can help us come up with a diagnosis, including skin thickening. I talked about again in this specific pattern involved starting in the hands and can extend up the arms and evolve the rest of the body. Telangiectasia is essentially these red dots, which is a sort of can be a hallmark of scleroderma as well. Patients can develop fingertip sores and ulcers, and then we often look at we can look at the nail capillaries or blood vessels and the nail folds too that can be associated with Raynaud's and increase our concern for something like scleroderma as well too. And we can, depending on the patient's exam, we could potentially make a diagnosis just on the physical exam alone. Blood work is also an important part of our evaluation. We want to look at sort of usually do a complete blood work to see if there's evidence of other organs being involved. And then there are a few antibodies that are associated with scleroderma that can help confirm a diagnosis and then also predict what organs might be involved, including RNA Pol3, SCL70, and centromere. And depending on a patient's symptoms, we might check do another markers for autoimmune disease as well. And then heart and lung testing is also a very important part of our evaluation for scleroderma because it's patients are at high risk for having lung inflammation and of the blood vessels in the lungs being affected. So any patient that has a new diagnosis of scleroderma is important to screen for these. So one is doing pulmonary function testing, which looks at the sort of respiratory mechanics. This is usually done at a specific site, and we'll have to like blow into spirometer to do this. We'll also usually get a scan of the chest to look at signs for inflammation in the lungs. Which you can see here. Again, the lung should look black, but here you can see this whiter areas is inflammation. And then we'll look at a scan of the heart or echocardiography to look specifically to look at if there's evidence of changes to the blood vessels in the lung. And I think these are very important to diagnose early and monitor closely. Is why we screen all patients for. And again, so through this different workup and exam, again, we hope to make a diagnosis. Again, many patients we evaluate might have certain features that are concerning. So they might have new Raynaud's and a positive antibody, but don't necessarily meet the clear diagnostic criteria. So we might just monitor them. And again, I think it's important to know which organs are involved to tailor our treatments. And there are a few things that part of our evaluation that can help predict, again, since there are so many organs that can be involved with scleroderma, might predict what organs are involved, what sort of complications patients might have. For example, distinguishing this limited versus diffuse disease help predict which organs might involve. For example, patients who have limited disease that are at higher risk for having pulmonary hypertension, which is when the blood vessels in the lung are affected, and patients with diffuse disease are more likely to have interstitial lung disease or inflammation in the lungs, and then their kidneys can be involved as well. And then the antibodies that we use, again, the different antibodies are associated with limited versus diffuse, and then they can sort of predict patients with certain antibodies are at higher risk for different manifestations. So one of the antibodies, centromere, is associated with limited scleroderma. Patients are at higher risk for pulmonary hypertension, whereas patients with SEL70 antibody are at higher risk for developing a more progressive lung disease. I can take a pause here to see if there are any questions to, all right, I think don't see that there. Yeah, I don't think there are questions right now. So now I'm going to talk through sort of with each, some of the different manifestations of scleroderma and how they might present. And then talk about some of the treatments we use, which again, there is no one treatment for scleroderma, and all of the treatments are tailored to different symptoms and organs that are involved. So as I go through each, I'll talk a little bit about some of the treatments. And particularly, I'll emphasize more some of the behavioral sort of and patient-centered things to manage some of these symptoms, and sort of briefly overview some of the medications that we'll use too. So the first, again, and probably one of the most common symptoms is Raynaud's, which can lead to fingertip ulcers and sort of ischemia or lack of blood flow to the fingers. Again, Raynaud's is often one of the first and most common symptoms that patients have when they develop scleroderma. And I think what we worry about most with Raynaud's is that it could lead to ulcers in the fingertips that can be very painful and difficult to heal, both and sort of in combination with some of the skin changes. So what are some of the things that patients can do to help control Raynaud's? So cold and stress are often triggers for Raynaud's. So it's really important to avoid both of those. One sort of important thing is not necessarily completely sort of intuitive, is that it's really important to wear layers and keep the core warm. So even though it's the fingers that are involved, keeping the core warm is really important in managing, but also using mittens and gloves and hand heaters, avoiding the cold as much as possible, which I know is not easy often in Boston. So these are all like very important to sort of avoid how much Raynaud's is affecting patients. And then again, our biggest, we want to avoid having ischemia and ulcers. Another important thing is avoiding stimulants. So nicotine can worsen Raynaud's, so can other stimulants like caffeine, cocaine, methamphetamines, or sort of amphetamines are all can worsen Raynaud's. And the treatment for Raynaud's is usually sort of most commonly vasodilator medications to sort of improve blood flow. Usually the most common ones we use are calcium channel blockers, which are more commonly used as blood pressure medications. So amlodipine and nifedipine are the most common ones we use. And then PDE5 inhibitors, sildenafil and tadalafil, are other medications that we might use if behavioral modifications and calcium channel blockers aren't controlling patient symptoms. And there are a number of other treatments that are sort of have varying degrees of sort of efficacy and evidence, but are other things we might try if the sort of the other medications aren't enough. So sort of angiotensin receptor blockers, another blood pressure medication, olorosartan, SSRI, which are often used to treat depression, anxiety, or fluoxetine. Topical nitrate is something, again, patients cannot use it with a PDE5 inhibitor, where they can, it's a topical medication they put on the webs of the fingers. That can be used, especially if there's like one finger that's particularly involved and the patient's not able to be on sildenafil. And then there is an IV medication if we're for severe ischemia, if we're which the patient needs to be admitted, usually in the ICU, to be monitored very closely, which is something that will can be used again to rescue if we're worried about sort of severe ischemia. The next sort of, again, common manifestation is skin thickening and inflammation. Again, we talked about different patients have different degree of how much skin is involved and then how severe it is too, and how much it's limiting their function and how uncomfortable it is. So early disease can often, the skin often be very puffy. It can also be very itchy. But then as disease progresses, the skin can thin. But sort of some of the things that we worry about and try to avoid is limiting mobility. So patients can have contractures in their hands and like a limited ability to open their mouth is some of the longer term things that we want to prevent that can really affect patients' ability to function and perform their daily sort of daily functions. And then what are the treatments for skin thickening and inflammation? So one important thing that patients can do, again, with a goal to prevent loss of mobility that we can see in some patients, is mobility exercises, particularly for the hands and face. Often the physical occupational therapists and physical therapists are really key for sort of providing these exercises and working with patients to maintain their mobility. And there's a nice handout from the National Scleroderma Foundation that sort of goes over some of a number of exercises for hand and face stretching if patients aren't able to see an occupational therapist or want some other resources too. And we also will, depending, again, not all patients will treat with immunosuppressive medication. So if the disease is more limited, if it seems very stable, we might not use immunosuppressive medications. The most common ones that we use are mycophenolate and methotrexate, which are oral immunosuppressive medications. And we often decide between these two, but based on what other manifestations patients may have. For example, mycophenolate also can treat lung inflammation. Methotrexate is better at treating joint inflammation. And then there are a number of other treatments that we might use if mycophenolate and methotrexate aren't sufficient, including IVIG, some IV medications, cyclophosphamide and rituximab. And we don't perform autologous stem cell transplant here, but that's sort of another treatment option in other institutions that's not commonly used, but an option for very severe disease. And then another common involvement is gastrointestinal involvement, particularly gastric reflux. Gastric reflux is very common. Many of our patients, I feel like most of our patients have some gastric reflux. Scleroderma can involve many other parts of the GI tract, affecting esophageal motility, difficulty swallowing. There can be abnormal blood vessels in the stomach. Patients can have diarrhea, constipation. They're at high risk for having bacterial intestinal overgrowth as well. So I'll talk a bit about some of the precautions and treatment for gastric reflux. And this is particularly important in patients who have lung involvement too, because having untreated gastric reflux can worsen lung inflammation too, and contribute to lung inflammation. So again, some of the behavioral modifications that are important: avoiding spicy foods and anything that might trigger your symptoms, avoiding alcohol and smoking, and then trying to avoid eating prior to sleeping or being supine, and then keeping the head of the bed elevated, usually around 30 degrees when sleeping, can also help to manage and prevent sort of reflux from the into the lungs too. And then there are a few medications that we use for gastric reflux that are very common medications. So one is proton pump inhibitors, omeprazole or pantoprazole, or a couple of these. These can be taken once or twice daily. It's very important to take them 30 minutes before eating. And then famotidine or H2 blockers are other medications we might add on as well too. And then next, another common manifestation of scleroderma is interstitial lung disease. Patients may present with cough, shortness of breath, low oxygen. Again, it's variable how patients can be affected. So some patients can have findings on imaging that never really progress, and then some patients can have really severe disease that progress and sort of really affects their functioning. The patients, so I think distinguishing between who will be most affected and most likely to progress helps us decide who gets treatment. Some of the patients at highest risk of having interstitial lung disease, and particularly progression of their interstitial lung disease, is patients who are most likely to progress in the first 3 to 5 years of presentation with new scleroderma, and then they're more likely to have severe disease if they have diffuse skin involvement or the antibody SCL70. And then the treatment for interstitial lung disease, often we work with our pulmonologists and co-manage with the pulmonologist to come up with the best treatments. So the most common medication often used is mycophenolate, which is this an oral immunosuppressive medication. This can also help the skin. Recently, tocilizumab was a new FDA-approved medication for interstitial lung disease, and it's shown particularly to be effective in patients who have diffuse skin involvement and are early during their disease. And then sort of again a number of other treatments, rituximab, cyclophosphamide, that we might use if patients continue to progress on mycophenolate. And then again, depending on their imaging and whether sort of the pattern of the imaging involved, another medication, we might use antifibrotic medications that specifically target more the fibrosis rather than the inflammation. And this is again another FDA-approved treatment for scleroderma lung disease is nintedanib. But again, not all patients who have ILD, especially if it's only involving a small part of the lung, other parts of their disease aren't associated with high risk of progression, may not be treated. But again, this is why this screening but we do think it's very important to screen and detect interstitial lung disease as early as we can. And then just a couple other sort of manifestations and symptoms I wanted to go over. Another is pulmonary hypertension. This is essentially narrowing of the blood vessels going from the heart to the lung. Patients can present with shortness of breath, but it is also can have chest pain. It can have edema in their legs. We can screen for this pulmonary hypertension with lung function tests and then the heart ultrasound. Again, part of the reason the screening tests are so important. But to ultimately diagnose pulmonary hypertension, patients typically will get a catheterization where usually either a pulmonologist or cardiologist will do this testing, where they use sort of put a catheter into the heart to measure the pressures. And then again, our typical initial treatment is these PDA5 inhibitors that we often also use to treat Raynaud's, sildenafil and tadalafil. And then finally, I wanted to talk about scleroderma renal crisis, which is not a common, one of the less common manifestations, but I think very important one to know about. So scleroderma renal crisis is where there's the kidneys, the blood vessels in the kidneys are infected, and usually it presents with high blood pressure, and then lab findings can be that there's abnormal kidney function and low blood counts. This is a medical emergency, so often patients, this is why your provider might ask patients to monitor their blood pressure closely, and why it's so important if you have scleroderma to have new high blood pressure to immediately seek medical care. Patients, particularly patients who are high risk, so these are patients with diffuse skin involvement, early during their disease, have the antibody markers of RNA Pol3, in particular if patients are on glucocorticoids. This can be a trigger of scleroderma renal crisis or associated with higher risk of it. So we often will avoid steroids in patients with scleroderma whenever possible, but sometimes it might be necessary for treatment of things like interstitial lung disease. And the treatment of this, again, it's important to be treated under really close monitoring. So usually, so patients are admitted to the hospital, and we use ACE inhibitors or one of such as lisinopril or captopril to treat it. And again, if it's not treated, it can go on to kidney failure. So that's why it's so important to know about this and get prompt evaluation for it. And then I just want to emphasize, again, I talked about a number of different organs that can be involved by scleroderma. Rheumatologists, which Dr. Castellino and I are often important in making the diagnosis, but there are so many other providers that are important for managing patients, depending on which sort of organs are involved and what manifestations they have. Particular occupational therapists and physical therapists are so important for maintaining mobility, but again, also depending on sort of which organ involved, we co-manage these patients and with pulmonologists, gastroenterologists, hand surgeons if they're have evidence of ischemia, and then nephrologists, cardiologists, and then also the foundations and support group are really important for supporting patients too. Again, there are multiple, in addition to sort of the treatments I talked about, there are multiple ongoing trials to try to improve management of scleroderma. We have a couple here at MGH that you can look into the details of through the Rally website at Mass General that provides more description of them and how to reach out to us if you're interested in learning more. And then just wanted to give a few resources. The National Scleroderma Foundation, and which also provided some of the printout I talked about with the hand and face exercises, the Scleroderma Research Foundation, and then Facing Scleroderma is a book that edited by and created by some of our colleagues here at MGH too. Is I use this for creating some of this presentation and is also another resource. So yes, in summary, scleroderma is an autoimmune disease that can affect a number of different organs from the skin, lungs, kidneys, joints, and gastrointestinal tract. Common early symptoms are Raynaud's, skin changes, and shortness of breath. And it can affect a number of different organs that we talked about. And again, we target treatments based on which organ is involved. So yes, with that, I can take any questions in the chat. Yeah, so let's see, I think I can read.
I'd be happy to help moderate too. There's a question regarding whether weightlifting can worsen shoulder joint pain associated with scleroderma.
Yeah, I think I not necessarily specific to scleroderma, but I think the type of weightlifting is important. So so I think there are definitely some exercises that might help strengthen the shoulders, but I don't necessarily think specific to scleroderma, but in general, like I guess doing weightlifting unsupervised without proper form could worsen shoulder pain and prompt shoulder injuries as well too. Again, I don't necessarily think this is something unique to scleroderma.
Oh, go ahead. I was going to say there's a question regarding if you've noticed if blood pressure in the arm is affected by limited scleroderma.
So in terms of if blood pressure in the arm is affected by, I'm not aware of, I don't think it's one of the typical manifestations of particular, like one arm being affected versus the other. But again, patients with limited scleroderma are less likely to develop scleroderma renal crisis, which is one of the biggest things we worry about with high blood pressure in patients with scleroderma. But if someone had new high blood pressure, we still would sort of evaluate them even if they had limited scleroderma. Usually the vessels involved are the more distal vessels. So often it can be really hard to get oxygen reading for patients, but like I'm not aware of, like, there are definitely other types of vasculitis that can be involved more proximally closer to the heart that might affect the blood pressure readings, but I'm not aware of how blood pressure would affect the arm in limited scleroderma. I don't know if you have another answer.
Yeah, so there's, I'll just jump in here. So the skin involvement for limited is typically the elbows and down. And in either way, if you have diffuse or limited scleroderma, it doesn't affect the reading itself because the skin is still superficial.
Thank you. And we have a question, bear with me, and also feel free to follow along in the chat. When blood work shows ACA and anti-SCL70 positive and clinically only Raynaud's, no other involvement is shown, could limited disease be diagnosed? If so, what is the probability and timeframe from onset of first symptoms of Raynaud's and development of internal organ damage?
Yeah, so this is a good question, definitely a common patient that we'll see in evaluation in rheumatology. So I think based on that information alone with the Raynaud's and the antibodies, that alone might not be enough to give a diagnosis. It's helpful. This is a case where sort of doing the whole workup that we do. So like looking for nail fold capillaries, any sign of pulmonary hypertension, any sign of ILD, if there are multiple like skin findings or like abnormal nail fold capillaries, any sign of pulmonary hypertension, if like a few of those are involved, that might be enough to give a diagnosis, but just the antibodies and Raynaud's alone might be a patient that we want to monitor closely of their symptoms and exam and rheumatology. But again, that wouldn't necessarily, that information alone without all of these other findings wouldn't necessarily give a diagnosis. I don't necessarily have a great statistic of like how likely they are to progress, but that would definitely be someone that we'd be worried that they could progress to develop scleroderma. And
there's a question regarding whether scleroderma can resolve on its own or is it something that's lifelong?
Yeah, so typically we think of scleroderma as a lifelong disease, but again, depending on how what your symptoms are. So some patients may have limited disease, and they may have like often skin thickening will improve over time. So they may have limited disease that sort of the skin thickening improves and thins over time. I wouldn't say that it completely resolves, but some of the symptoms might improve. And again, if there's less organs involved, more limited skin involvement, then the patient's long-term may never need treatment, may not necessarily have symptoms that affect their lives, but I don't usually think of it as like completely resolving necessarily. Hopefully that answers the question. And again, there are some patients again who might have ILD that is sort of only affecting the small portion of the lung, not causing symptoms, that may not go on to cause more symptoms or need treatment. But so it may stay stable and not affecting the patient very much, but I don't usually think of it as like completely resolving. And you might be at lower risk of, especially since some of these complications are highest for progressing in the first 3 to 5 years. So they might have decreased risk of having progressive lung disease if they've had the disease and it's been stable for 10 years. Yes.
Thank you. While we wait to see if we have any additional questions in the chat, would you mind sharing a little bit more about our scleroderma program and what a first visit might look like?
Yeah, I don't know. Again, I can talk about what a first visit might look like. Maybe I'll give it to Dr. Cazzolino to talk more about the scleroderma program. So again, a lot of what a first visit might look like, again, is usually involving asking a lot of questions. We'll look very closely, do a full physical exam, look very closely at your skin and your hands. We might look for nail fold capillaries to evaluate for nail fold changes. And then usually we'll talk about, again, depending on how the exam is, how concerned we are for scleroderma, we'll likely do blood work and might decide whether or not we also need to do lung function testing. Again, in this scleroderma, it's usually you'll see a rheumatologist, you'll see just the rheumatologist. We don't necessarily have a multidisciplinary sort of center right now that you'll see multiple providers unless you're in the rheumatology dermatology clinic, which is separate from the scleroderma center. Yes.
I'll just add on to that. So thanks, Laura. So typically after a patient is seen in our clinic, if you do need a referral to a pulmonary hypertension specialist or a lung disease specialist, we'll place that referral and we work closely with the different specialists in the different specialties. Part of the program, there are some other clinicians as well that see patients in the scleroderma program. So you'll be assigned to one of us, including Dr. Yockey. And there is a research arm to the program as well, where we have a scleroderma clinical registry, where we collect patient information, and patients as part of this registry will do surveys and have a blood draw annually. This may not affect you directly as a patient, but it helps us understand the disease and follow the trajectory of the disease. So getting back to that question about the antibodies and development, registries can be really helpful to see the progression of scleroderma. So it's really helpful as a patient, if you're asked to participate in a registry at whatever institution you may be at, certainly think about that because it can help the future of scleroderma. And then as part of the program, we also have clinical trials, as Dr. Yockey mentioned. So certainly if you're not responding to specific therapies, a clinical trial could be entertained if you qualify. So that still is a possibility to give you the opportunity to have access to new drugs.
Thank you. And I see that you shared a few resources. Thank you so much. Dr. Castellino shared some links to the National Scleroderma Foundation and the Scleroderma Research Foundation. Feel free to save those, as well as the link to the Blum Center website. This session is being recorded, so if you want to view the recording, you may visit the Blum Center website for that. All right, so I think that's all that we have for questions. I think it'd be okay to end a few minutes early, but before we end today's session, do you have any final thoughts you'd like to share with the audience?
No, yes, thank you all for being here today. And again, yes, appreciate all your questions and that you're here.
Thank you so much, Dr. Yockey, for spending the hour with us.
All right.
And for everyone who took the time to join, thank you so much. Hopefully you found today's session helpful. If you have any questions, feel free to email the Blum Center at pflc@partners.org. Thank you, everyone. Take care.
Thank you. Bye-bye.